Good morning. Wanted to do this lecture on PrEP and PEP today. I think most of you know me, Dr. Ladd. I'm the Assistant Medical Director of our OSU Ryan White Clinic, and just wanted to share a little bit about pre and post exposure prophylaxis. Just a faculty disclosure, I did sit on the Gilead Advisory Board November 2018. And I am a member of the V Pharmaceutical Speakers Bureau currently, last year, as well as this year. None of that should impact the presentation. Many of the drugs that we are utilizing are from these companies, but they are not being promoted. I will just be really going through the guidelines and FDA recommendations. Learning objectives, we're going to review through non-occupational post-exposure prophylaxis guidelines, as well as the occupational ones. And then we will try to spend most of the presentation on pre-exposure prophylaxis. And then I would like to use some time at the end to review the Discover trial week 96 data that was presented at the CROI conference virtually this year. So just to begin, I think most of you know the difference between PrEP and PEP. We do talk about PrEP quite a bit, but post-exposure prophylaxis is important to know as well, as sometimes patients may be exposed, need a post-exposure prophylaxis, and then be converted over to a pre-exposure prophylaxis. Ending the HIV epidemic, a plan for America that Trump discussed last year in his State of the Union address. And then we started noticing this plan coming out with additional funding, particularly for Ryan White clinics. There are certain areas that were targeted, particularly 48 counties across the nation with a high rural burden, with 48 counties throughout the nation that were targeted, as well as 7 states with a rural burden, and Oklahoma was one of those states. So we are currently awaiting additional funding for that. When we talk about it, it's different pillars. It was pillar to diagnose, so more testing needing to be done. Then for treatment, which is the funding that we're awaiting to hear on. Prevention funding has been distributed, and there has been some distribution for federally qualified health centers throughout the state that we have contracted with, so that when they are testing during these times and we get an HIV positive patient, that we can get them into our clinic and be able to treat. But these prevention pillars are important because these are primary care physicians that are treating through these federally qualified health centers in Oklahoma, so that we can get PrEP to our rural communities. And then response. So these were the 4 pillars in terms of HIV ending the epidemic. First, I want to go through non-occupational post-exposure prophylaxis. And again, I'm going to go through post-exposure pretty briefly. These guidelines date back to 2016, and there has not been an update since that time. So these are the guidelines that I'm going to talk about today. The main thing is this is when somebody has been exposed, and it's within 72 hours that we're wanting to write for the post-exposure prophylaxis. This is non-occupational, so this is someone that is exposed to a partner of substantial risk of HIV. And there's certain parameters that you can take into play that will give us an idea of how that exposure risk is, particularly knowing what body fluid they were exposed to, the exposure site, and knowing the source of that possible infection and their status, and maybe even knowing their viral load. All of these things can be beneficial. Remember, it's within 72 hours of the exposure that this can be utilized. This table 1 will show us some of the areas where there's higher risk for exposure. I think you're mostly familiar with that in terms of looking for exposure with blood transfusion, needle sharing, IV drug users, and then anal intercourse or any unprotected sexual intercourse can be a risk, especially when the partner is HIV positive, and particularly when they're not on HIV medications. And then you can see some of the less likely instances where somebody may get HIV. So it just kind of gives you a little bit of an idea of that exposure risk. And then also knowing the method of exposure. evaluation is pretty similar to what we check when we're looking for someone for PrEP too. So we're doing HIV testing, hepatitis B and C, other sexually transmitted infections. We're looking at a pregnancy test if it's a female, and then usually checking our liver and kidney function. You want to know all the labs at baseline for the exposed and the source. You really only need the creatinine and the liver function for the exposed. If we're going to be placing that patient in post-exposure prophylaxis, it's nice to know the viral load of the source. This is important. And then we're going to repeat HIV testing at intervals 4 to 6 weeks, 3 months, and 6 months, and then hepatitis testing at 6 months as well. So let's look at the non-post-exposure prophylaxis. It's a 28-day regimen. You guys are familiar with these drugs. And so in this situation, the guidelines state that we can use dolutegravir once daily, so that's Tivicay, or raltegravir or Icentris, but remember that's 400 milligrams twice a day, or if we're using the long-acting in this situation, it's still, remember, 2 pills. And that's combined with tenofovir disoproxil, emtricitabine, better known as Truvada once daily. This is indicated for patients with a creatinine clearance over 59, and this is our preferred regimen. It's a 28-day regimen for post-exposure prophylaxis. And then remember that if the risks are there, then we need to talk to them about converting from post-exposure prophylaxis right into PrEP. Okay. This slide just lists an alternative regimen that can be utilized. And so in here, it's saying that instead of using the integrases and as on the previous slide, that you could also use protease inhibitor, and that would be darunavir with ritonavir. Once daily. Remember, that has to be taken with food for absorption. Again, 28-day regimen. If the creatinine clearance is less than 60, there's an alternative regimen listed here for treatment. We want to look at risk reduction. And so remember, again, you want to make sure you're talking to them about PrEP following and PEP. So again, that was just a quick review. I want to go through occupational post-exposure prophylaxis. Most institutions have a protocol for this, and so you want to follow the protocol of your institution. These guidelines as well date back, and we're looking at guidelines that were initially written in 2013, but they were updated in 2018 with a few additional changes. So when we talk about occupational post-exposure, and we want to refer to the guidelines if we're not looking at a protocol that our institution has, we're looking at basically a healthcare provider that has been exposed, and we're looking at most of the time a percutaneous injury. That's about 0.3% of our occupational post-exposures, and then that means you want to look at an increased risk in those situations when there's visible blood on the device. If the needle was in an artery or a vein, of course, that's going to increase your risk, or if it was a deep injury. The other mode of contact could be contact with the mucous membrane. So this is 0.09%, so it's a lot less than if it was a percutaneous injury. And then you also want to look at, or if it was any exposure of non-intact skin with blood, tissue, or other body fluids. But there's other body fluids. We're not talking about urine, feces, sputum. We're really talking about, was it a paracentesis or a thoracentesis, and it was a fluid from one of those. Those are considered more potentially infectious than if it was urine or sputum. So the preferred occupational post-exposure prophylaxis is preferred regimen is with raltegravir or Icentris, 400 milligrams twice a day, and then tenofovir disoproxil or Truvada once a day. Again, it is a 28-day regimen, just like it was with non-occupational. You want to start it as soon as possible within that 72-hour window, but as soon as possible. So if you know within 12 hours or within 2 hours, you want to start it as soon as possible. And it's administered for that 28-day period. We need to determine the source patient's HIV status. And remember, even if we find out that person you were exposed to is HIV positive, and you're able to obtain the viral load, and you know that the viral load is undetectable, it is still recommended that post-exposure prophylaxis is done for that 28-day period of time. Also, you want to remember on the back end, within that 72 hours, you really want to make sure that you're reevaluating that patient, or person that was exposed, and then you want to make sure we get follow-up time in place. So we're going to be redoing testing at 6 weeks, 12 weeks, and 6 months after the exposure. But now that we're using more fourth-generation tests, some of that actually changed with the update, in that you can actually do the testing at baseline 6 weeks after the exposure, and then 4 months after exposure. So you could change that a little bit if you're doing an HIV antigen antibody immunoassay. Okay, so fourth generation test. Also, you want to make sure while they're on this regimen, CBC 2 weeks after exposure, renal hepatic function, so CBC CMP 2 weeks after exposure, make sure they're tolerating your medication. One of the things that that I want to make sure you know about is a PrEP line and a PEP line. And sometimes we've had to utilize these because even in a occupational post-exposure prophylaxis, I've seen other integrases used, because remember, raltegravir is twice a day. And so if we want to increase compliance in a regimen, being able to use once a day and using something like dolutegravir, and I've seen that utilized in regimens when somebody has actually called the PEP line and gotten those recommendations. So I wanted to make sure that you knew that this was available through the University of California, San Francisco, UCSF. Okay, so now really I just wanted to talk mostly about PrEP, or pre-exposure prophylaxis. So for this patient, this was a very sexually transmitted infection. The next could be for HIV. And so this is actually off the Truvada healthcare provider website. It's truvadahcp.com. And I think that most of you know this because we have an HIV clinic, but when patients are coming in for other sexually transmitted diseases through emergency rooms, urgent cares, any of those things, if they test positive for something like syphilis, an HIV test really needs to be done. How many times do we see a new HIV patient in clinic and they tested positive for syphilis and found out they had HIV? I can't begin to say how many times this actually happens. And so this is the point that I like emphasizing the most when I do primary care lectures, is just not to forget that when we're seeing some of those other sexually transmitted infections, and we know a lot of them are out there, that patients are getting HIV testing at that time. So let's go ahead and talk about PrEP. The United States Preventative Services Task Force does recommend it as a grade A, that clinicians offer PrEP with effective treatment for PrEP, so utilizing Truvada or tenofovir emtricitabine, who are at risk for HIV acquisition. So it is recommended. So what is PrEP? So we know it's pre-exposure prophylaxis, and right now the indication is to use Truvada or tenofovir disoproxil with emtricitabine. But that has been around since 2012. But in 2019, we did get FDA approval for Descovy, which is TAF, tenofovir alafenamide with emtricitabine. So I'm going to call FTAF for Descovy, FTDF for Truvada. We know, as utilizing these drugs as part of HIV regimens, that they're safer in terms of renal dysfunction and bone. But Descovy or FTAF was not indicated for all, because was studied in only cisgender males and transgender females. So currently we are not utilizing this regimen, and it is not FDA approved in women or in are really IV drug use, but it's mostly our MSM population that are cisgender or transgender females. So This indication came out in 2019, but our PrEP guidelines are from 2017 and have not been updated. So by the guidelines, it is still using FTDF, but FTAF is approved by the FDA and can be utilized for MSM that are transgender or cisgender. Okay, and just as a reminder, knowing that TAF is a prodrug that's absorbed more quickly than TDF, and so we get higher levels of active drug, but that's actually in the cell. So the active drug tenofovir diphosphate is in the cells, but we can actually give it in smaller doses. So we're essentially getting lower levels in the blood, so lower levels affecting our kidneys and lower levels affecting our bones or other organs. But there can be some benefits to using FTDF or Truvada, and those would be things like there's more of a lipid protective effect. So we'll talk about all those things as we do the comparison in the Discover trial at 96 weeks. I want to show you a short video that just really tells us the basically the way that PrEP works.
People are talking about PrEP, but what is it and what does it do? PrEP means pre-exposure prophylaxis, and it's the use of medication to help keep someone who does not have HIV from getting infected with it.
I'm gonna fast forward a little.
These cells normally help keep you healthy when you're exposed to a germ or virus. But when HIV enters your body, it hunts down these T cells, attacks them, and uses them to make copies of itself at a very high rate, as many as several billion copies per day. These new copies of the virus go out into the body and hunt for even more T cells to take over, using them to make even more copies. The immune system just can't keep up with the virus to stop it from making all those copies. And that results in HIV infection. Now, let's rewind and see what would happen inside your body if you were exposed to HIV while taking PrEP. Imagine that you start taking PrEP once a day. Your body digests the pills, and the medication starts building up protection for your T cells. After taking a pill each day for about a week, your T cells are getting maximum protection. Then you are exposed to HIV. As before, HIV tries to attack your T cells, but this time, because you've been taking PrEP, it doesn't succeed. It tries to get into the cells to make copies of itself, but it can't because the cells are protected. The result? No HIV infection. How should you take PrEP? PrEP comes as a pill that you should take.
Okay, very good. So I just wanted to show you part of that video just so we can see kind of how PrEP is working in the body. Just to be able to show you, this is what Truvada looks like, the blue pill, and Descovy just side by side with Truvada, and being able to see that Descovy is a smaller pill. I think most of you know that. PrEP recommendation. So daily use is versus on-demand use. And so I do want to spend a little bit of time on this slide, just being able to delineate the difference. So on-demand use, or basically event-driven, is not FDA approved in the United States, is not recommended by the CDC. On-demand use, though, is used in other places, and they do use it in Europe. What is on-demand PrEP? So 2-1-1 dosing. So basically they take 2 doses before intercourse. They're taking 1 dose 24 hours after the first dose, and 1 dose 48 hours after. Okay, so this was only utilized in MSM, and that is how it is recommended in Europe. The study, IPERGAY, actually looked at this, and they looked at 400 patients and looking at the primary endpoint of seroconversion. 19 patients in that trial, so there were 400 patients total, 19 seroconverted, but 16 actually seroconverted after enrollment. 2 were in the TDF-FTC arm that got on-demand PrEP, and 14 were in placebo. So there was essentially an 86% relative risk reduction in that study. But when they looked at it a little bit further and were looking at how many doses these patients were taking, median number of doses were 15 doses a month. That was over 3 to 4 doses a week. That was 10 sex acts per month and 8 partners every 2 months. So that then makes us think about the study and do we need days for the active drug and PrEP to build up to an optimal level? Well, in the study, you can't tell because they were taking so many doses. And then would it work for MSM if they were having sex less frequently? So these were the concerns that came up and why it's currently not FDA approved or CDC approved for use of that as PrEP. And so our PrEP is daily use of Truvada by guidelines or now FDA approved Descovy. Remember, we want to look at all of these things when we're looking at that study and the high frequency of sex and IPERGAY, as well as the increased pill taking because of the number of times they were having sexual intercourse is what really, is that what made the difference in the study or not to get the 86% relative risk reduction? So it's not known whether if you're basically having less intercourse, if it's still effective. That's what we're not sure about. Does it need buildup in the rectal tissues if we're utilizing it as an MSM? Again, that's the other thing we're not sure about. So candidates for PrEP. When we look at guidelines, the way it is stated is it's substantial risk of HIV acquisition in one of the following. So they're sexually active in their MSM, sexually active and they're heterosexual, men and women, or it's a person using IV drug use. All of those were grade 1A recommendations. And then on the next slide, I'm going to define what the substantial risk of HIV acquisition is. But it is inclusive of quite a few patients that we could be candidates for PrEP. Also, uninfected partner in an HIV serodiscordant couple. So remember, that means one partner is HIV positive, one is HIV negative, but during the time of conception and pregnancy. So this was a 2B recommendation. In the guidelines. Remember, again, these guidelines are dated, but especially if a viral load is present in the HIV positive, there's an increased risk of HIV acquisition during pregnancy. And so this is something that we need to really consider. And then there was insufficient data in adolescents. So this was a 3B recommendation. FDA is approved now for greater than 35 kilograms, but there's lack of data in the age group less than 18, especially because I feel like they're still growing, there's still bone growth there, and could there be some effects of tenofovir on this bone growth? There was an adolescent trial network, or ATN 082, but when you actually look at the trial, the ages of the population were 18 to 22. So looking at that substantial risk of HIV. So that could be an HIV positive sexual partner. It could be somebody with a recent sexually transmitted infection, syphilis, gonorrhea, chlamydia, all of which we see much of. High number of sex partners, a history of inconsistent or no condom use. Well, that's probably the most common that makes them fit that criteria. Commercial sex work, or people who are using IV drugs and injecting with an HIV positive partner or sharing equipment. And essentially, this is looking at the same thing, just in a table format, but this is pulled right out of the guidelines, so you can access this. I just wanted to make sure that you had a visual of it. If you're more of a visual person, that may make a little more sense and quick to access. So identifying eligible patients. So, the biggest thing here is really looking at a sexual history. And you guys know this because we talk about getting a sexual history in our HIV patients all the time. It's very important. Currently, and this is just interesting data, only 18% of patients who are at risk for having HIV are currently prescribed PrEP. And that is a very low number, 18%. So I know I can't emphasize enough like how many times we need to be evaluating patients for PrEP. Also, I want you to keep in the back of your mind, and I know you've heard attendings say this before too, if a patient comes in asking for PrEP, they're coming in asking for pre-exposure prophylaxis. That means that the risk is there. Maybe they're not comfortable talking about it. Maybe you try to take a sexual history and they're not forthcoming, but it may just be that they're not comfortable talking about it, but the risk is there and they're most likely a candidate as well. Okay. So another interesting fact, only 23% of sexually active men and 47% of sexually active women report receiving a sexual risk assessment in the past year by their healthcare provider. So tells us that providers are also uncomfortable getting sexual histories. I know all of you are comfortable with it because we have an HIV clinic, but many primary care physicians out there are not comfortable getting a sexual history. What's very important when we're talking about PrEP, and it's very important when we're talking about HIV, because I think it's a big part of our education component of things, of telling patients not to share IV needles if they're using IV drugs, or making sure patients are utilizing condoms. So just knowing that we can get a sexual history so we can figure out if somebody's eligible, particularly if somebody's an MSM or they have both male and female partners, or one or the other. Are they having anal intercourse? This is important, and this is important to really ask men and women. And whether, then I'll also like to ask at the same time the status of their partner. Then, are they HIV positive? If they're positive, are they on HIV medication? Are they undetectable? There's a lot of information that we can ascertain at that particular time. And then, just really, are they the top, or are they the bottom? You want to know those types of things because different things are transmitted, and it increases risk if you're having anal intercourse or if you're not. So, and then you want to know if they're utilizing drugs, because remember, if they're utilizing drugs, then a lot of times they're having a lot more riskier behaviors with sexual intercourse as well. And then heterosexual, you want to basically ascertain the same things, same questioning there. So, okay, again, these tables I've taken out of the guidelines. And so these are the indications, but basically it's going to be a person who does not have acute HIV. So remember, I'm going to talk about this later, but you want to make sure you screen and make sure they're not in the middle of converting, they don't have acute HIV. You guys are very familiar with what those signs and symptoms are, and I'll go over those in a little bit. And then really, have they had a partner in the last 6 months and they're not in a monogamous relationship? And then one of the following: have they had sex without condoms, or have they had a sexually transmitted infection? Okay, so those are essentially, just to sum up the 2 boxes, and that's essentially what you want to know. And then it's a little bit different for injection drug users, and that's in that box B3 there. And you basically want to know if they're sharing any of that drug equipment or needles. So equipment too, it's important to ask about that. And I find that most of the time patients are forthcoming about it. So assessment of risks. So you want to make sure that you have HIV testing done. And most of our tests are 3rd or 4th generation. You can get a rapid blood test, but not the rapid oral when you're doing these HIV tests to just before you're starting them on PrEP, because of the time frame of when you actually could convert. And you want to screen to make sure they don't have any signs and symptoms of acute HIV. Our preferred is a 4th generation, and when you're using labs, because that's when your window is the smallest, when you're using a 4th generation antigen antibody testing. Okay. Interestingly, in the studies that were done, we'll talk about IPREX and Partners PrEP a little bit later, but those that became positive and they did not have any resistance to the components of Truvada, they converted during the study. But those where it was unrecognized that they had acute HIV in the beginning and then figured it out after initiating PrEP, some of those did have resistance, and the resistance that showed up was an M184V mutation. And so this was an IPREX as well as Partners PrEP. So this is the reason that we really emphasize making sure a patient doesn't have acute HIV at the time of initiating PrEP. So you want to know that your HIV test is negative before you initiate PrEP. You want to know the renal function, especially if you're using Truvada. You want that GFR to be greater than 60. Hepatitis B status, you want to make sure that's negative. Remember that Truvada is also treating their hepatitis B, and if they abruptly stop it, they can have a hepatitis B flare. So this is important. It's also important to make sure that they're vaccinated. I think that you guys are pretty familiar with all that with our treatment with HIV. Hepatitis C status, you want to know that too, especially if it's a drug user. Or remember, hepatitis C can also be transmitted through anal intercourse. And so you want to know Hep C status, because for later on, that may be important if they may need to get hepatitis C treated, and just making sure there's no drug-drug interactions. Sexually transmitted infections important. So syphilis, gonorrhea, chlamydia, especially if they're MSM, but we're going to be checking that. And then you want to know if it's a female, if they are pregnant. I also wanted to just quickly remind you that in pregnancy, there's an associated increased risk of HIV acquisition in pregnancy, especially if partner has a detectable viral load. We kind of mentioned that earlier. So it is off-label use in pregnancy because of unknown data for the developing fetus. But it is used, remember, we use these drugs as part of HIV treatment, even in pregnant women. So I just wanted to bring that up. Also, in terms of sexually transmitted infections, remember when one sexually transmitted infection is present, it makes the acquisition of HIV easier, more likely. So that is the reason for making sure we're checking those things. So acute HIV infection, just as a reminder, usually occurs within the first 1 to 2 months, can be a flu-like illness, fever, rash, headache, lymphadenopathy, diarrhea, fatigue, myalgias, and night sweats. And the rash can look similar to this and can be self-limiting, about 3 weeks. It could be flat or slightly raised. It's non-phoretic. And sometimes people don't even know the rash is there. It's very hard to pick up somebody during that acute HIV, but we've done it. I mean, we've seen patients who come in and remember having that flu-like illness, and that was most likely when they converted. So taking good history sometimes is needed. Remember, if you suspect acute HIV, do not initiate PrEP. We need to get a HIV viral load. You could also repeat HIV testing in a month, but if you want something on the spot, if they're converting, their HIV viral load is going to be through the roof. Even if their HIV test hasn't converted yet, the viral load is going to be really high during this time. They're replicating. And so this is essentially telling you the same thing, but just in a graph format for those of you that knew that I like flow charts. Sometimes it's just a quick read when you are accessing guidelines and be able to look at that in that format. Time to achieving protection. So this is interesting, especially from an education standpoint for the patient. Okay, so you want to make sure you're educating them appropriately. When you initiate PrEP, are they immediately protected? No. And so we want to make sure that we get that information across to the patient at a visit when we're initiating PrEP, right? So time from initiation of PrEP to maximal protection against HIV. The exact timing is unknown. So we have estimates, and those are by pharmacokinetics. So when we look at the steady state and the maximum intracellular concentrations of the tenofovir diphosphate, it's different by tissues. So a rectal tissue, it could be approximately 7 days, but it could be up to 20 days in blood or cervicovaginal tissues, and we don't really know in terms of penile tissues. So when you're educating somebody, if they're having anal intercourse, they may be protected in a week, but if they're having vaginal intercourse, it may be 3 weeks. So we really need, this is why the sexual history is so important, because the education piece on this part, in terms of educating the patient, you don't want them to feel like they're protected and having unprotected intercourse when they're really not protected. So we want to make sure that they have a good understanding of that. Prescription, so whether we're writing Truvada or we're writing Descovy for our MSM or transgender women, so remember, it excludes anybody having vaginal intercourse. That's an easy way to remember it. Then you're writing this prescription initially for a 30-day supply, because you want to make sure, one, that they tolerate it, and one, that they're being compliant with it before you hand over a 90-day prescription. We already talked about all those labs that we need to have in place prior to initiating it. Take it once daily, no food requirements. You guys have used these drugs and you're familiar with what to educate them about. After that 30-day supply, then we're doing 90-day supplies thereafter. Remember, we're getting that testing, and they have to have an HIV test prior to the next 90-day supply, because we want to make sure that they're negative during that time. That is very important. Advancing access and copay programs. You guys are familiar with the Gilead program and being able to utilize that so that patients can get access. Right now with Descovy, so Truvada and Descovy are both by Gilead, and right now there's 91% unrestricted access with no prior auths or step edits on most patients. So that's 84% commercial insurances, 100% of Medicare and Medicaid. The commercial insurances include Community Care, Blue Cross Blue Shield Oklahoma, CVS, Express Scripts, and Health Smart. So that is the most recent information in terms of coverage. And remember, there's patient assistance programs through Advancing Access as well. So what do we do for monitoring? We're following up at that 1 month appointment. That's after they've had that 30-day supply, and then we're seeing them every 3 months with HIV testing. We're checking renal function. Can be done every 6 months with a complete metabolic panel, but every 3 months if there's renal risks. Remember, especially with Truvada, because can affect our creatinine. Pregnancy test and sexually transmitted infection testing during those 3 months as well. You want to reassess every 12 months to make sure that the need for PrEP is still there. What's not recommended is DEXA scans, and then also therapeutic drug monitoring, not recommended. Remember, for those of you that have utilized Truvada before, most of the time before your creatinine elevates on your CMP, it's going to be protein in your urine. So you can easily do a urine dipstick. That's what we used to do in the old days when Descovy didn't exist and we had everybody on Truvada with their HIV regimens. Usually we could pick up on some proteinuria before we ever saw creatinine creep or creatinine rise. Or if we saw creatinine creep, we quickly got a UA to see if they had proteinuria. And we've even, when Descovy did come out, convert patients over and then recheck a urine that protein was gone. Remember, it also asks, you can also access whether they have protein in the urine or glucose in the urine, because the rare finding of Fanconi syndrome, you know, we've only seen a case or two probably through our clinic of Fanconi's, even when we're using a lot of Truvada, so it is rare, but it can happen. Another thing to utilize is a serum phosphate in patients who have chronic kidney disease. And again, there's a table that kind of goes through the same thing that can be accessed in the guidelines as well. So counseling, counseling. So important. What are we telling patients? So medication doses, how are they going to take it? You guys know this stuff as we're treating patients with HIV too. It's similar. We want to know what time of day are they going to take it? How are they going to fit it into their schedule so they don't forget doses? This is important because we want to talk about adherence and efficacy. So technically, if they're having anal intercourse, they're only required to get 4 doses per week for it to be efficacious. But if it's vaginal intercourse, then it could be 6 to 7 doses. And so remember, and also if they're having, so it depends on if they're the top or the bottom too, right? Because if they're not having anal intercourse, then I would assume they would still need the 6 to 7 doses for efficacy. Now, we don't want to tell patients this, but this is just so we can gauge when we're educating them about adherence. And then when they come back for the follow-up appointment, we're gauging their adherence for us to know if it's going to be efficacious. If you look at the trials, and we'll talk about the trials later, it worked if you took it, but if you weren't taking it, it wasn't working. And so that can be dependent on how many doses they were missing a week. So this is important. Potential side effects. So overall, it's well tolerated. Nausea, diarrhea, maybe some fatigue can be some of the side effects. In the trials, particularly IPREX and Partners PrEP, we saw headaches, abdominal pain, and some weight loss. And then for all NRTIs, it's always listed lactic acidosis and hepatotoxicity, but oftentimes we're seeing with the older NRTIs, but still listed on the package insert. Reduction of barriers to adherence. So, I mean, still talking to them about adhering to their meds, use of condoms, educating on what the signs and symptoms of acute HIV would be so the patient knows to make you aware if they should have any of that. And then making sure condom use, not sharing needles, education about other sexually transmitted infections, all of that being important. Why the dose difference? Remember, it's really the tenofovir concentration in the anal tissues versus vaginal tissues. So it's believed that the tenofovir concentrates 10 to 100-fold higher in rectal tissues than in vaginal tissues. And it's also cleared more rapidly from the vaginal tissues than the rectal tissues. So this is part of the reason for that discrepancy. Also, remember, you want to, at this time, also go through drug interactions. So is there anything interacting with TDF? Do you want to minimize drugs that may go through the kidneys, especially if you're using Truvada, not Descovy? And then if you need to co-administer it with drugs like, for example, hepatitis C, that can increase TDF exposure. You want to keep all those things in mind as we're moving forward. Persons with a new HIV infection, you guys know what to do with that. We want to confirm that it's HIV positive and get their routine HIV labs, including genotypic HIV resistance testing. In our clinic, we can easily transition them from the OSU IM clinic to IMSS and make sure all of that stuff is done. Remember, I always talk to patients about the confidential partner notification that can be done, as well as testing through the health department. So now let's talk about some of the PrEP efficacy trials that have been done in the past, and then we'll move on to the 96-week data for the Discover trial. So what I really want to kind of start, let's start with IPREX. And really this was done in South America, Africa, and US and Thailand. Included MSM as well as trans women. And it was around 2,500 patients, okay? And the mean age of these patients was 27. Because of the distribution, 72% were actually Latino. Our primary endpoint was, did they seroconvert to HIV? So 48 patients in the Truvada arm did, and in placebo arm were 83. But what they did find is many of the patients in the Truvada arm, so 31 out of 34 that they looked at, had no detectable level of the drug. So again, if they weren't taking it, it's not going to work. And so many of these trials that did show efficacy, and even though if they had high adherence, they showed efficacy strongly correlated with the adherence. So initially looking at that trial, it showed 44% efficacy. Okay, but then when they looked at it by if there was a detection of the drug, and then recalculated the efficacy, it actually increases then up to 92% when we look at actually detectable drug present. Okay, so when we look at partners PrEP, it was a little bit similar. Now, this one was done in serodiscordant heterosexual couples. So one's HIV positive, one's HIV negative. The HIV positive partner was not on antiretrovirals, so it did have a viral load. Median CD4 of 495. The median age of the patient was 33. And primary endpoint, again, was seroconversion. So we're looking to see, did they seroconvert to HIV positive? Okay. In this trial, Truvada arm showed 13 that seroconverted, and placebo arm was up at 52. So 13 versus 52. Out of that, they looked at 12 of the 13 patients, and 9 of them did not have detectable levels of the drug. So again, we're looking at a 75% efficacy when we looked at it up front. And then when we looked at whether there was detectable level of the drug, recalculate the efficacy, it went up to 90%. Okay, so both of these really, I mean, overall did have high adherence in these trials, but the ones that patients that weren't adhering, we recalculate that efficacy and we really get a higher efficacy. So basically the drug works if they use it. Efficacy strongly correlates with adherence. Okay, TDF2 study, and the Partners PrEP was done in Africa. I forgot to mention that. TDF2 study was Botswana, and this was a smaller portion. The other two, I mean, when we look at IPREX, were 2,500, and Partners PrEP was almost 5,000 patients. So that was quite a bit. TDF2 was only 1,200 patients, 62% efficacy, but when we measured again the detection of the drug, efficacy increased to 85%. Okay. Not really going to talk much about FemPrep in boys. These were done in Africa and they were done in women, but there was a very, very, very low adherence in these trials, less than 40 and 50% in terms of adherence. So the trials were stopped for futility due to that. And then the last one done in Bangkok, Thailand, it was done in IV drug users, and 50 were infected or seroconverted, 17 in TDF arm, and 33 in placebo. This was all in IV drug users, 49% efficacy, but when they measured the drug again, it went up to 74%. So I just wanted to mention some of those so that they would be basically familiar to you. But now I really want to move on to the Discover trial. So this is long-term efficacy and safety of FTAF, so Descovy, and FTDF, or Truvada for HIV PrEP. So this is a Discover trial, week 96 results presented at CROI conference, which is our conference on retroviruses and opportunistic infections. This was at the beginning of March 2020, done virtually. So initially, CROI 2019, they had looked at the preliminary data. So it's an ongoing phase 3 randomized trial looking at efficacy and safety of FTAF, or Descovy, for PrEP among cisgender men or transgender women who are having sex with men, so MSNs, at high risk of HIV infection. And so the initial data in 2019 looking at CROI, but they hadn't completed all the way through. They had 100% that had completed through week 48 and 50% through week 96. And at that time when they analyzed it, they noticed that FTAF was non-inferior to FTDF in preventing HIV. Both drugs were well tolerated, low side effects, and that FTAF had a significantly better bone and renal profile versus FTDF. But now we can look at the 96-week data. So I wanted to show you the study design of Discover. It was randomized 1-to-1 to the different arms, double-blinded, active controlled. So it's not open label till after week 96. We're looking at FTAF, or on the bottom right-hand corner of the screen, I'm showing you the trade name. So Descovy versus Truvada, 2,500 patients in each arm. Remember, these are cisgender MSMs or transgender women having anal intercourse. So this is not vaginal intercourse. Women were not in the study unless they were transgender women. So eligibility, they had to have 2 episodes of condom-less anal sex in the past 12 weeks or had to have rectal gonorrhea, chlamydia, syphilis in the past 24 weeks. They had to be HIV negative, they had to be hepatitis B negative, and they had to have a creatinine clearance greater than 60. That is because they could potentially be in the TDF arm. And prior use of PrEP was allowed. It was about 16 or 17% of the patients that were included in the trial. Study was conducted in Europe and North America, and there were separate arms done to look at renal and bone as well as metabolic factors. So we will look at all that. Also wanted to mention the 2 arms. So they received, in both arms, each patient received 1 placebo drug and 1 active drug because, as you know, Truvada and Descovy look differently, right? Descovy is a smaller pill. And so they just wanted to make sure that they were truly blinded. Participant disposition, say week 96, and overall there was a low discontinuation rate, 81 to 82% still on study drug at the time of the primary analysis, which is pretty high retention rate. Looking at the demographics of the Discover trial, median age was age 34. You can see the racial demographics there. 62% of patients having greater than 2 condomless receptive anal intercourse sex partners within 12 weeks, rectal gonorrhea, chlamydia, syphilis fairly high, and had taken PrEP previously, 16 to 17%. So primary endpoint analysis. So here they show you week 48 as well as week 96. So primary analysis showed 22 HIV infections in a total of 8,756 person years of follow-up. Okay, and you can see in the 2 arms the 0.16 or the 7 infections with FTAF versus the 15 infections or the 0.34 in the FTDF or Truvada arm. Now looking at it at week 96, there is a total of 23 infections. So there was 1 additional infection, and that infection was due to poor adherence. So here we are again seeing that if you're not taking the drug, it's not working. Poor adherence, they had low detection level of drug in their system. Okay, and so this concluded at week 96 that they could ascertain that FTAF was non-inferior to FTDF for HIV prevention. And when we look at our incidence rate ratio, we are well below our non-inferiority margin of the 1.62. Overall safety, similar adverse events, basically in both arms. It was well tolerated. Only 1 to 2% had adverse events that led to discontinuation, which is excellent. And many of the adverse events were sexually transmitted infections. That was probably some of the most common. Here, just want to show the high and consistent rates of sexually transmitted infections throughout the study. There was rectal gonorrhea present in 21% of participants, which correlated with HIV incidence, and greater than 57% with at least 1 sexually transmitted infection while on the study. So that's just the top part of that slide there. We're going to look at bone safety, and this was a sub-study taking 375 patients and looking at the bone mineral density. They all had DEXA scans done at baseline, at week 48, and at week 96. And reported fracture events were similar in both arms. Okay, there were 65 in FTAF and 64 in FTDF arm. When we look at previous studies, just looking, we've talked about iPrex now and Partners PrEP. Partners PrEP didn't really look at bone mineral density evaluations, but iPrex found no correlation between bone mineral density and fractures with Truvada. So there was a 1% decline in bone mineral density. It happened within the first few months, but then stabilized or returned to normal. And there was no increase in the fragility fractures over that 1 to 2 year period. Now, what they did with this study, taking those 375 patients that were being evaluated for bone mineral density, they then look at it in comparison to age. So here we look at patients with that were over 25. These were, the last slide was all comers, and we see actually an increase in bone mineral density with FTAF, and we noticed a decrease of bone mineral density with FTDF or Truvada. That was spine and hip. Now in this slide, we're looking at the same thing, but looking at it with the patients that were over the age of 25. Now we look at it with patients that were over 25 and less than 25. So the ones that, the broken dotted line are the patients less than 25, and you actually see a greater magnitude of increase in the bone mineral density changes in both arms. So patients who were on FTAF saw a little bit of a greater increase in bone mineral density, and those that were in FTDF a bit of a more of a decrease in bone mineral density. And that just implies that in both groups there was growth in changes occurring in patients that were less than 25. So the dotted line is, again, less than 25, and we're seeing a greater magnitude of change. And they believe this is due to both growth or changes occurring still in that age group less than 25. Looking at renal safety, now they looked at renal biomarkers, and we don't know the clinical significance of renal biomarkers. It's unknown at this time. But we did see that there was a less of a change in the FTAF arm than in the FTDF arm with our EGF arm. And then same with our biomarkers. Renal discontinuations were low at 6, and Fanconi syndrome was only 1. Then we looked at renal safety in age population greater than 50, seeing a similar trend there as on the previous slide. And then we looked at renal safety in patients who had eGFR 60 to 90 and really seeing similar findings here. And now looking at fasting lipids and glucose at week 96. Remember, when you're looking at this slide, if you've used Truvada before, you've used FTDF, you know that it has, TDF has a lipid lowering or a lipid protective effect. And so this is essentially what we're seeing here is we saw a greater decrease in the total cholesterol and LDL with FTDF than we did with FTAF. But then it evens out when we look at our total cholesterol to HDL ratio. Fasting glucose were about the same in the two arms. They also looked at body weight and BMI, as this has been a big discussion recently with FTAF. And essentially, we're seeing FTAF in green and FTDF in gray again. And you can see that there was about a 1 kilogram difference between the two arms. Both essentially had some amount of weight gain, but it was a 1 kilogram difference between the two arms. So in conclusion, FTAF did remain non-inferior at 96 weeks to FTDF for HIV PrEP. And we did see differences between FTAF and FTDF when we compared bone and renal safety. Bone mineral density declining greater than 3%, common with the FTDF arm, but more pronounced in younger patients, so as patients less than 25. The renal biomarkers remained more favorable in participants taking FTAF than in FTDF. And this included older participants over the age of 50 and those with a reduced GFR. TDF was associated with greater declines in LDL and HDL, but total cholesterol to HDL ratios or fasting glucose remained similar across the two arms at week 96. Weight gain was observed in both arms at week 96, but approximately a kilogram greater in participants taking FTAF than FTDF. This was similar as what has been observed in IPREX. So FTAF is a safe, longer-term option for PrEP, but keep in mind that is PrEP for your MSM population only, or it can be in your transgender women, but not approved for women at this time. So it is patients having anal intercourse. Another point to remember if you're trying to decide whether to use Truvada versus Descovy, younger patients particularly, we do have patients less than the age of 25. They may be at greater risk and there may still be bone changes occurring. So this may be a population to target. Anybody with risk of osteoporosis may be safer to use Descovy or FTAF, and anyone with chronic kidney disease, it may also be a safer option. Again, our PrEP line and our PEP lines here, just wanted to make sure that you have that information. And these are just some experiences from patient portals that we see. I know all of you have heard stories like this. I'll let you read that one on your own. But all of us have heard things like this and know that we can make a difference by writing PrEP for our patients at risk that are HIV negative, that we don't want to be seeing as a new patient on our HIV specialty side. Remember that it's very easy. This blogger says, you know, a patient comes in, has a sexually transmitted infection, asks for PrEP, you test him for HIV, hepatitis, vaccinate, talk about sexually transmitted infections, get some labs, talk safer sex for a bit, and then you give him a prescription, and it can be that easy. So basically, are you ready? Just wanted to leave you my references there. Most of these guideline sets are available on aidsinfo.nih.org. All of you are familiar with our guidelines there for HIV. There is MPEP, occupational PEP, and PrEP, separate guidelines all there. Some of my information on statistics, etc., aidsview.org, our Discover trial slides from the CROI conference of 2020. Remember our PrEP and PEP lines from UCSF. And then there is healthcare provider information at truvadahcp.com as well. Thank you so much. Hope this has been helpful. Have a great day.